Let's begin with chapter 33. I won't be discussing the entire chapter. This is just a review. I won't be going through the whole anatomy because the assumption is you passed A&P1, so you should know how to trace the flow of blood. This will help you recognize why the signs and symptoms appear the way they do. It's really because of a disruption in the flow of blood. So beginning this semester, you'll have your first exemplars for perfusion problem. So we have several cardiac chapters. So 33 is the assessment chapter. 34 are dysrhythmias, which will be in your fifth semester. Chapter 35 will finish this semester. 36 as well, except the aneurysms part. 37 are vascular disorders. Wait a minute. 37 is shock, sorry. And 38 is acute coronary syndrome. So 37, 38 will be in fifth semester. But the concepts will be the same. So whatever you learn this semester, you carry it on to the next future semesters. All right. So the concept remains the same. So when we see each other in the fifth semester again, the concept remains the same. We're just using this different exemplars that time around. So this time we'll only be using heart failure as the main example of decreased perfusion. So let's begin. So this is your anatomy. You have your coronary arteries here. Cross section will be on the next figure. So this is a cross section of your heart, and this is what you see here. So this is your anterior, and this is the posterior view. So you have the big vessels there, superior vena cava, inferior vena cava, both returning blood into the heart, entering the right atrium, passes the tricuspid valve, entering the right ventricle, leaves the heart via the pulmonary arteries, left and right, going to the right and the left lung. And then they return to the heart via the pulmonary veins, entering the left atrium, passes through the mitral valve, and then into the left ventricle, and then finally out into the aorta. So you see these first three branches here. These are the left and right carotid arteries. Therefore, the first organ that really receives blood here is the brain. So whenever you're looking at signs and symptoms of decreased perfusion, the earliest symptoms therefore will be mental status changes, like specifically syncope or fainting. So the patient will have fainting cells because there's not enough oxygen getting to the brain. The heart actually is the second one that gets it, because during diastole, as the heart ventricles are not pumping, so blood falls back onto the aorta, and that's when blood enters the coronary arteries and then perfuse the myocardium. So same thing for the right and then left side. So these are your coronary sinuses right here. And the lungs will be third, I guess. Well, actually, the lungs will be number 2, because they also fill during systole, and the heart fills during diastole. So there will be branches here, which is hidden, not visible in this figure, but there will be branches out of the aorta supplying the lungs, right? So if you think about it, the lungs have a dual circulation. The lungs get blood here when the blood is pumped through the left and right pulmonary arteries. Okay, the lungs get blood right there, and then they get blood again as the blood now leaves the heart and the aorta. Some branches supply the lungs. So because of that dual circulation there, you very seldom hear about a pulmonary infarct. We hear an MI all the time. We have myocardial infarction, but we never really hear about pulmonary infarct. That's because there's dual circulation for the lungs. Okay, so in that, because of that structure, it's almost impossible to infarct it because there's plenty of blood vessels supplying the lungs. Let's discuss a few things here. So when we talk about any cardiac problem, it really boils down to three elements. So the number one, what's the one job of your heart? Miss Boger, what's the number one job of your heart?
To pump blood to every part of the body.
Okay, and what does that blood carry?
Oxygen.
All right. So
And
therefore,
other stuff also, but yeah, oxygen.
all right. So therefore, can you say that the job of the heart is to circulate oxygen?
Yes.
All right. So to help it do its job, there's really three elements that have to be present in order to make perfusion possible. So perfusion is oxygenation, or particularly this is called cellular oxygenation, because we have gas exchange at the lungs, but it doesn't stop there. The lungs aren't the only organs needing oxygen. That oxygen exchange at the alveoli in the lungs have to be circulated to the rest of the body. And that's where the heart comes in. But it can't do it on its own. So three elements must be present in order to make perfusion, which is again the delivery of oxygen to the body, possible. So there has to be good contractility. You have to have vessels that adjust size in order to um, respond to the various needs of the body, meaning the blood vessel can dilate and it can also constrict in response again to your needs. And then finally, you have to have enough blood volume to circulate the blood containing or carrying oxygen. So let's begin. So if the heart's contractility is impaired either by a electrical conduction problem, meaning you have dysrhythmias, AFib for instance, or ventricular tachycardia, VFib, VTAC. So the heart in electrical conduction problem is not beating at the right rhythm. So therefore, there's no regular atrial contraction timed correctly between ventricular contractions. A cardiac cycle, for instance, is the lub-dub, right? Lub is the first sound, S1. And then we have dub, which is S2. These heart sounds are produced by, of course, the valves opening and closing, right? Particularly closing. So when valves close, they produce the heart sounds. So if there is a irregular heartbeat, irregular electrical conduction, will there be a good timing between atrial and ventricular contractions? The answer is no. So if there is no correct timing, will there still be a unidirectional flow of blood? Sorry, I was not sharing the screen. I'm supposed to be sharing. Okay, sorry about that. So can you see my screen now?
Yes.
Okay, so I was talking about perfusion. So these are the three elements. So last thing I said was electrical conduction. So we have dysrhythmias, which is in chapter 34. So this will cause a a disruption in the flow of blood. As we described earlier, blood should only flow in one direction. Back to the anatomy. So blood should go one way. So they enter the heart, leave the heart, go to the lungs, return to the heart, and then leave the heart again. So they should only go one way. So just like in grocery stores, we have one-way aisles now. You're not allowed to go back the wrong way, correct? We have one-way streets for obvious reasons. We want to maintain an orderly flow of traffic, that we don't have any congestions, no traffic accidents. So same thing with blood, the flow of blood through the heart. They should only go in one direction. Once you enter, you move forward. You go out and then you return one way. So do you see any arrows here that are going back the other way?
No.
No, the flow of blood only goes in one direction. So in the case of first example I gave was the dysrhythmias. So if you have an electrical conduction problem wherein there's no correct timing or rhythm as the heart beats, will there be a orderly flow of blood?
No. No.
No, that is now disrupted. So now we have a problem. Cardiac output will necessarily drop, blood pressure drops, perfusion suffers. Next problem. What if we have a structural problem, which we will discuss probably in 2 weeks? The structural problem, I'm referring to valve disorders. So what if one or more of these valves in your heart okay, that's better. All right, so what if one or more of these valves either do not open or do not close properly? So let's say either the tricuspid or mitral or the pulmonic or the worst, the aortic valve. So let's say they become calcified due to, say, aging or high cholesterol, smoking, or any other lifestyles that a patient is doing throughout several years, several decades. So they cause damage now to your valves. So the valve either is very narrow, doesn't open completely, and or does not close properly, does not completely close, because lub-dub again is necessary in order to maintain one flow of blood. What if imagine if one or more of these valves do not open completely? Will there be enough blood moving forward? So let's say from the right atrium to the right ventricle, if the tricuspid valve doesn't open completely, it's stenosed, what will be the amount of blood entering here? Is it normal?
No.
No. Meanwhile, there's enough blood returning from the lower part of the body and the upper part of the body. They're now congested here. So now there's traffic here because this here, it bottlenecks because there's no sufficient opening. It does not open completely. Or what if it's the other way around? What if it doesn't close completely? So after the blood leaves the right atrium, entering the right ventricle, as the ventricles contract, the tricuspid and the mitral valve are supposed to close shut to prevent blood from going back to the previous chamber. What if it doesn't do that? What if this damage, this is leaky, so some blood returns back there? Will that also disrupt the unidirectional flow of blood?
Yes.
Okay, so I can go on and on. So there can be structural problems, there can be electrical conduction problems, or final problem in chapter 35 is there could be an infection. Where there's an infection inside the heart, the parts that could be infected are either the innermost lining, the endocardium, or it could be the muscles themselves, the myocardium called myocarditis. So we go from endocarditis to myocarditis, or worse, it could be the sac surrounding the heart. So it could be pericarditis. So there could be, again, as a summary, there could be an electrical conduction problem. There could be structural problems, meaning involving the valves. And then finally, you could have an infectious or inflammatory problem involving any of the three layers of the heart. And the last part of chapter 35 is cardiomyopathy, which is heart disease itself, meaning there's a abnormal heart. It's not strong, meaning there's a weird shape of the heart, weird diameter of the walls, therefore they're not functioning normally. So regardless of the problem, everything we'll talk about in chapter 35 will result in failure. Before we go to management and the signs and symptoms, let's get these two terms out of the way, because we said that there were three elements, correct? There are three elements that are necessary in order to maintain perfusion. So we said there has to be a properly contracting body. There has to be vessels that can adjust diameters in response to the changing perfusion needs of the body, and then there has to be enough blood volume. Contractility obviously refers to the heart. This is referring to how good or how bad is the patient's heart. Structurally speaking, or electrical conduction wise. Right?
Professor, we don't really hear you that well.
Yeah,
Okay.
it's getting like a little bit cut up, like for the past like few minutes.
Okay, but is it manageable?
At times, I mean, it's either really good or really bad.
Okay, just anytime it goes bad, please let me know. Okay.
Right now.
All right. Thank you. Jenna, why don't you start us off? Please tell us preload.
Preload refers to the degree of myocardial fiber stretch at the end of diastole and just before contraction. The stretch imposed on the muscle fibers results from the volume contained within the ventricle at the end of diastole. Preload is determined by the amount of blood returning to the heart from both the venous system, right heart, and a pulmonary system, left heart, left ventricular and diastolic LVED volume. Should I keep reading?
Thank you. That's good.
Okay.
So based on what you heard Jenna read, which element is preload referring to among the three elements of perfusion? Is it referring to the heart, the vessels, or the blood volume?
Blood volume.
All right. It's referring obviously to the blood volume. Volume was mentioned a few times here. So volume, amount of blood returning to the heart, which is volume again, right? And then end-diastolic volume. So preload is referring to the amount of blood entering and leaving the heart. Any question on the concept of preload? We'll discuss how these work, but do you understand preload so far?
Yes.
Okay. Make sure you understand, because when we go to the next chapters, 34 to 38, they will not explain preload and afterload anymore. The only place you'll see the explanation is in chapter 33. So these terms will now be used constantly in the next cardiac chapters, right? So it's really important that you understand the term right here, because again, they won't explain what it is in the next chapters. Next is the afterload. What is afterload, Mr. Christopher? Chris? Okay, let's hear from Miss Alexa. What is afterload?
Do you mean to read it?
Yes, please.
Okay. Another factor affecting stroke volume after, oh wait. We're talking about afterload, right?
Yes.
Sorry. Stroke volume afterload is the pressure or resistance that the ventricles must overcome to eject blood through the semilunar valves and into the peripheral blood vessels. The amount of resistance is directly related to arterial blood pressure and the diameter of the blood vessels.
All right. So given again the three elements, which element is afterload referring to? You said that volume is preload, and contractility obviously is referring to the heart as a pump. What is afterload?
The blood vessels?
So it says there, this is the resistance imposed by the valves or the blood vessels. So it's directly related to the diameter of the vessels. So to explain it, if this is the diameter of a normal blood vessel, a really bad drawing. Okay, and this is the diameter of a constricted blood vessel, and this is now the diameter of a dilated blood vessel. Because remember, blood vessels are smooth muscles. They can contract, they can dilate, meaning there are tiny capillaries within the walls of the vessel itself, meaning think of it as a vessel within a vessel. So the vessel wall is a smooth muscle. They are capable of constricting, like this one. This is constricting. And number two, this is dilating. So they can change the diameter of the, see how the diameter changed? So this one is your normal diameter of a blood vessel. This is now a constricted blood vessel. And this is now a very dilated blood vessel. So describe the, so let's say we circulate 5 liters. Let's say at any given time, the average blood volume in an average person is about 5 liters of blood. If you circulate 5 liters here, which is the normal size, so let's say your blood pressure here is less than 120/80. And then when you constrict it though, you still run the same 5 liters through this blood vessel wall right here, this diameter of the blood vessel. What happens to your blood pressure?
Increases.
All right, because now there is higher resistance, so it will increase blood pressure. What if the same 5 liters run through this very dilated vessel? What happens to blood pressure?
Goes down.
Drops.
Right? Because there is no resistance, right? There's not enough resistance. So again, afterload is referring to the resistance directly imposed by the diameter of the vessels, or the opening of the valves. As I described earlier, the valves can either be stenosed or regurgitant. They either do not open completely or they do not close completely. Any questions so far on the 3 elements? All right, I forgot the blood volume. Okay, so if normal blood volume is 5 liters, what happens to blood pressure if we increase it to 8 liters? What happens to your blood pressure?
Increases.
Very good. What happens if it's only 3 liters?
Decreased.
Very good. So you understand the relationship between preload, afterload, and contractility. So let's say we have a weakened heart. So this heart right here suffers a heart attack. So this is the left anterior descending coronary artery, which is blocked. So you have a huge infarct here, a very big blood clot, killing the entire left ventricle. So is the pump still okay? You
Say that
think?
again, Professor? I'm sorry.
Can you repeat the question?
Okay. So this is the left anterior descending coronary artery, which is now blocked by a huge blood clot. So this is an MI. It kills the entire left ventricle. So is the pump okay?
No.
No.
So, but the pump has no choice. It has to keep beating, whether it's injured or not. It has to. It has no choice. What will happen if normally before the heart attack, it was able to carry 5 liters? Now that it suffered a heart attack, can it carry 5 liters?
No.
Not efficiently, no.
No.
Obviously not, right? It can't carry 5. Can it carry 8?
No.
No.
That's even worse. It can't even carry 5. How much more 8? However, can it carry 3?
Yes.
Yes.
Possible.
Right, 3 is more manageable. So therefore, in a patient with heart failure, what do we do with the preload in order to help maintain perfusion, to maintain cardiac output? Do we increase or do we decrease preload?
Decrease.
We decrease preload. Let's go to the blood vessels now. So same heart who suffered a heart attack. Can it, if what will happen if, let's say this is the normal diameter of the vessel, you think it can still pump the same 5 liters through this same opening of the vessel? Can it carry 5 liters and pump it through this vessel right here?
No.
Can it still do that? Meaning the same amount of preload, normal preload, and then normal afterload. Can it pump that 5 liters through the normal
Yes.
vessel after a heart attack?
Oh, no, no.
Not effectively.
No, right? So what about if we constrict it?
Possibly, yeah.
So it can do better compared to this. It can pump it better on this one. Because now you're gonna squeeze 5 liters through this narrow blood vessel right here.
5 liters? No. No.
5 liters, yeah, 5 liters, and this one, it's even narrower. This is your original vessel, but then the vessel wall thickened or constricted, narrowing the lumen. So now the heart who just suffered a heart attack has to pump 5 liters to this number 1 vessel right here, which has a narrow opening. Can it do that?
No.
No.
No. What happens to cardiac output?
It goes up.
Decreases.
Drops. However, what about this vessel right here? Vessel number 2. If you dilate it and it now pump 5 liters through that larger opening,
Yes.
absolutely. So therefore, in a patient in heart failure, what do we need to do to the afterload? Do we increase it, number 1, or do we decrease afterload, number 2?
Decrease.
Okay, so let's summarize. In a patient who has a weakened heart in heart failure, what do we need to do to the afterload?
Decrease.
What do we need to do to the preload?
Decrease.
Decrease. Are we clear on that?
So you can decrease both the afterload and the preload?
Yes.
Okay.
And then finally, what do we need to do to the heart itself? Because now it's weakened. It is now injured.
Slow it down.
Do we need to increase its contractility or decrease its contractility to maintain perfusion?
Increase.
All right.
Increase.
So now we will give medications that will, number one, increase contractility, decrease afterload, and decrease preload. Any question?
I get it now. Sorry.
So this is the story of any heart problem. So in all our succeeding chapters, chapter 34, which are dysrhythmias, chapter 35, which will cover heart failure, valve diseases, infectious diseases or inflammatory disorders, and then cardiomyopathy. And then 36, which is covering the vascular problems, 37 covering shock, and then 38 covering acute coronary syndromes. What do we do to the contractility, the afterload, and the preload? Because all of those conditions lead to heart failure. We need to do what to the heart again, to the contractility? We want to
Contractility.
increase it.
Inc-
About the afterload and preload.
Decrease.
Decrease it.
Right. So don't forget that. Okay. So regardless of what chapter we go through in the future, these are what you do for every patient who has heart problems. We want to maintain a low afterload, low preload, and increase contractility. All right. So every time your patient displays any heart problem, I'm only talking about heart problems, okay? Do not confuse this with what we learned in chapter 11, because in chapter 11, if you remember, what did we do to the preload of a patient who was dehydrated?
Increased.
We increased it, right? We gave IV fluids or blood products. What about with a patient who had fluid overload? What did we do to the preload for those patients?
Decrease.
Decrease it.
We actually decreased it. So do not confuse these. So here you see the concept of perfusion here. So in the context of a heart which is injured, which is unable to do its normal job because it is injured by various causes, electrical conduction, structural problem, for instance, it is unable to do its job. So our goal, therefore, is to help the heart maintain perfusion despite its injury. Doing so, we will have, in order to do so, we will have to decrease afterload, we'll have to decrease preload for the rest of this patient's life. Is that clear?
Yeah.
All right, so let's go back to textbook. All right, so we're clear with preload, afterload. One last thing. Let's review Starling's law. Who remembers Frank Starling?
Probably from high school, but not recent. Learned
Yeah.
in high school.
Remember his history? He was one killed in Central Park. He was shot.
Okay.
No, I'm just kidding.
I was about to say, I don't think that's it, but whatever you say, Professor.
Okay, so Frank Starling postulated about the stretch. Okay, so his example, his law, his theory, which is now the law that we follow with heart management, cardiac management, is the blood pressure is directly related to the amount of stretch of the ventricle, meaning the more you stretch the ventricles, the greater the resulting contraction. Meaning the more preload you put into the ventricle, the greater the resulting contraction, the greater the blood pressure, the greater the cardiac output. However, there's a however here. Excessive stretching or excessive filling of the ventricles also can lead to decreased cardiac output. Now, how do we explain this? So it's just like a rubber band. Miss Ashley, recall the time that you bought a brand new underwear. Okay, so you brought a new undies. All right. So the first few weeks or months that you were using it, do they stay on your hips well?
Yeah.
When you stretch it and then you let it go, does it snap back in place?
Yep.
Yeah. Fast forward 2 years later, because you had to use it, it's your favorite pair of undies. You wash it, a few times a week, after you only give it maybe 1 to 2 days break, and then you put them on again. They're the most comfortable pair you own. 2 years later, does it still do the same?
Not
Yeah.
not not quite like the first day.
Yeah, not anymore. So it's just like what happens here to your heart. So as long as the stretching is periodic, not constant, meaning as long as this patient's blood volume stays normal and um, maintain their medication, for instance, not smoking, not having a high sodium intake. So as long as the preload stays the same, it will not overstretch the heart. However, doing so, let's say you eat chicharron almost every day, you have you love bacon and steak, for instance. Okay, so you have this high salt intake, smoke all the time, excessive alcohol, less fruits and vegetables. Okay, so that will increase not only the preload but also the afterload, because we know that plaque deposits will now form in the blood vessels, increasing afterload, right? Because now you narrowed the lumen of your arteries, because there are now fat or plaque deposits within the walls. Does that make sense?
Yeah.
Okay, so therefore, over time, heart disease will increase. Heart disease developed because you have a high preload and a high afterload. So therefore, it only makes sense that when you have heart disease, our goal, therefore, now will be to lower preload and lower afterload. Any question?
No, Professor.
All right, let's go to the compensatory mechanisms now. We discussed them already in chapter 11, but we need to look at them in the context of heart disease now. All right, some of the common problems, because heart disease, any cardiac problem results in decreased perfusion. Perfusion, again, is the delivery of oxygen to the tissues, and how we deliver oxygen is through delivery to circulate blood, because blood, particularly hemoglobin, carries the oxygen. So therefore, the heart, we're asking a lot from the heart. So we're asking it to please deliver all this oxygen to all our customers, which is from head to toe. So the heart, along with the blood vessels and your blood volume, must work together in order to make sure that the delivery is constant, right? So of course, when you have increased oxygen demand, such as when you're having physical exertion, for instance, you're playing sports, or you are walking uphill, carrying a boatload of groceries, for instance, home, because let's say your car broke down. So that will increase oxygen demand, because now your muscles are exerting more. So it's in these increased oxygen demand episodes or circumstances that really test can your heart deliver? Can your heart adjust to, can your cardiovascular system adjust to that increased oxygen demand, or will you fail? When they fail, then there will be symptoms. So if there is now less oxygen delivery, not only to the rest of the body, but also to the myocardium itself. Remember, we discussed earlier that when does the heart perfuse? When does it receive blood? Is it during systole or during diastole?
Diastole?
It was during diastole. So the heart here is very selfless. It's prioritizing the brain and the lungs before itself. Right? So it prioritized delivery of the oxygen during systole to the other organs and leaving itself the scraps, okay, during diastole. So after, when they relax, that's when they receive blood. That's when the blood enters the coronary arteries. So therefore, if there is not enough oxygen delivery, then the patient has symptoms, namely angina, or worse, it's an MI now. Then we have the rest, pericarditis. And the most common symptom here is dyspnea. Dyspnea, unfortunately, is not exclusive to heart disease. We see dyspnea in pulmonary disorders as well. In fact, we also see dyspnea in psychological disorders. You've seen people panic, have a nervous breakdown, or a major mental meltdown, okay, a panic attack. They have dyspnea too, right? With no cardio or pulmonary disorders involved. So therefore, we have several causes of dyspnea, but particularly here in cardiac, it is dyspnea on exertion. Exertion can be ordinary activities, or it could be extraordinary activities, such as, say, climbing a mountain, for instance. Stairs, we do that every day. Another is orthopnea. Orthopnea is the inability to breathe easy when they are lying flat. So this is a common symptom of heart disease. So they have orthopnea. So our normal question when we triage these patients or when we do assessments is, how many pillows do you need in order to sleep well? Or some people may not be sleeping in bed anymore because of this difficulty, though, so they will start sleeping in the recliner now, and that will be for several years. And then finally, which is almost exclusive to heart disease, is what we call paroxysmal nocturnal dyspnea. We'll explain later how this develops when we get to chapter 35, although it's also explained here. This is dyspnea that wakes you up in the middle of the night. So here, if you read the pathophysiology, how this forms, it's really well, it's a long story. It resulted in, it came from decreased cardiac output, which caused less urine output. Therefore, because there's less blood getting to the kidneys, so normally how much urine are we supposed to make every day in chapter 11? So in 24 hours, how much urine output are we supposed to have? How many liters? Hello?
I forgot, Professor.
It's about 1500 ml.
Wow, I was gonna say that, but I was scared.
So if the patient is now no longer making 1500 ml of urine every day, what happened to the rest of the water that is supposed to come out?
It's pooling, or it's accumulating in other areas.
All right, so that's why the patient gains weight. So now at night, when there is less metabolic demand because you're now sleeping, all of a sudden, the diseased heart can now perfuse the body because there is less oxygen demand. So now the fluid now returns to the vascular circulation, causing the patient to wake up because there is suddenly increased blood volume. The preload increases all of a sudden because all the fluid that was accumulating in dependent areas, in the legs, for instance, in the sacrum, or even in the scrotum, okay, now returns to the vascular compartment, increasing preload, causing a sudden increase in preload, overwhelming the heart, causing the dyspnea, causing pulmonary edema. So it wakes the patient up. And then at the same time, the patient will also have nocturia. They'll have to get up several times a night because of all these increased blood volume, which is now reaching the kidneys. And now the kidneys are making up for all the oliguria that they were doing during the day. I mean, during the day, the kidneys weren't getting enough blood flow, so they were not making enough urine. Now at night, all of a sudden, they're getting all this blood, and now they're making all this urine. So combine all of these, so you have orthopnea, then plus you have paroxysmal nocturnal dyspnea, plus the nocturia. All of that will, of course, contribute to the fatigue. So does the patient get enough sleep?
They're gonna be up all night.
Not with getting up 2 to 3 times a night to pee, right? Plus, not to mention, of course, there's less oxygen delivery to the body. That will contribute to the fatigue even more. So these are the most common symptoms of heart failure. We're not specific yet. These are just general. It doesn't have to be heart failure. It could be an MI. It could be whatever is causing the decreased cardiac output. These are the common symptoms. You'll see this in chapter 35. Right? So look at how much water you have to retain before edema is even evident. What does it say? So once you see, let's say, there's already edema in the feet, what does that indicate? How much water have you accumulated? Thank you for reading, sir.
You want me to read the whole thing?
Right here. Yes, please.
A sudden weight increase of 2.2 pounds, 1 kilogram, can result from excess fluid, 1 liter, in the interstitial spaces. The best indicator of fluid balance is weight. Excess fluid accumulation is commonly known as edema. It is possible for weight gains of up to 10 to 15 pounds, 4.5 to 6.8 kilograms, or 4 to 7 liters of fluid to occur before edema is apparent. Ask whether the patient has noticed a tightness of shoes, indentations from socks, or tightness of rings.
All right, so the implication here is once you see edema in the legs, how much water has the patient now accumulated?
More than 10 pounds of water. That's crazy.
Between 4 and 7 liters, right? So does edema, peripheral edema, okay, I'm not saying, because pulmonary edema occurs faster. It can occur within hours. But with peripheral edema, pedal edema, for instance, or leg edema, does it occur within hours?
Say that again, Professor. I'm sorry.
How much does it take in order to accumulate 4 to 7 liters?
What do you mean, how much does it take?
How long? Yeah, how long will it take? That's over several days, right? So really, yeah, you don't see edema form right away. But the implication there is really significant because that means once you see edema in the patient's legs, that means how much water has the patient now accumulated and has retained in the body. And think of all that preload that they're carrying.
Right.
Right?
Mm-hmm.
Okay, so that will cause, of course, decreased perfusion. And then finally, although syncope is not also specific or exclusively found in cardiac problems, 80% of them though are usually cardiac. The other causes are usually maybe you have a seizure, for instance, or your blood sugar is low, those are the other causes of syncope. Or maybe you're having a stroke. However, 80% of the cases when somebody faints, it's usually a cardiac problem. Okay? Meaning it's a cardiac output issue. Not enough blood is getting to the brain. All right. Okay. Let's discuss this one, and we'll proceed with 35. Table 33-2. This is not really a lot. We will only memorize 2 here. This is my suggestion. This is how I survived this in nursing school, because really the significant numbers here are 2 and 3, because 1, look at 1. Read this for me, Miss Bolger.
So for class 1, patients with cardiac disease, but without resulting limitations of physical activity.
And
Ordinary physical activity does not cause undue fatigue, palpitation, dyspnea, or anginal pain.
okay, so no chest pain, no symptoms at all. What are considered ordinary physical activity? Taking a shower, is that ordinary?
Yes.
Yes.
Giving birth to a third,
Yes.
Yeah.
ordinary, right? That's ordinary physical activity. Walking to the mailbox or going to the grocery store, doing errands, those are ordinary physical activities. No symptoms. So do we need even to memorize class 1?
No.
No. So this is my technique. So I'll forget about that, because really I know class 1, they have heart disease, but it doesn't bother them. They have no symptoms as long though activity is ordinary. However, when these guys start mountain climbing, doing sports, do they have symptoms now?
Yes.
Yes, they will. But as long as their activity is ordinary, they have no problems. So again, do I need to memorize class 1? Yeah, that's a forget about it issue. So what about class 4? Do I need to memorize this? Look at class 4. Thank you, Miss Christina.
Sorry, Professor, I clicked the wrong thing. Patients with cardiac disease resulting in inability to carry on any physical activity without discomfort, symptoms of cardiac insufficiency, or of the anginal syndrome may be present even at rest. If any physical activity is undertaken, discomfort is increased.
All right, so do I need to memorize class 4? Because look at this. Even if they're not doing anything, do they have symptoms? Yes. Yeah, it says clearly there. Inability to carry on any physical activity without discomfort. I mean, anything. Okay, I mean, so if they just put their hands up to grab a cup of water, they're already short of breath. They're already having signs of angina. Okay, they're having chest pain. So these people, are these people able to leave the house?
No.
No. Going to the bathroom will be a chore here. They can hardly get out of bed, okay, without getting really short of breath. So these people are, when you say class 4, these are people waiting for a heart transplant now. These guys are not just bed bound, but homebound. They can't get out of the house. I mean, you can take them out, but you have to carry them out in the stretcher or
With the oxygen, right?
yeah, with oxygen too, because even at rest they already have shortness of breath. So they'll have to be on a wheelchair or on a stretcher. So very I mean, there's no way to live. Okay, they're pretty much pre-departure, right? Unless they get a heart transplant. So really, what we're left with is class 2 and 3. So this is what I would memorize. So class 2, I know class 1, nothing. Class 4 is the worst. Class 2, if I do ordinary physical activity, there is slight limitation, meaning I can, let's say when I take a shower, I will have symptoms. Okay, so look, ordinary physical activity, so which is a shower. When I take a shower, I get short of breath. However, when I take a rest, when I stop, let's say sit down on a shower chair, am I okay?
Yeah.
Yeah. So as long as I sit down when I have the symptoms, I'll be okay. So that's class 2. But look at class 3 now. There's now marked limitation of physical activity, comfortable at rest, but at least in class 2, I can do ordinary physical activity. That's when I have symptoms. But here, less than ordinary physical activity causes symptoms already in class 3. So this is what I would memorize, class 2 and class 3 only. Does that help?
Yeah.
Yes.
With class 2 and up, they would have orthostatic hypotension.
Which one? Class?
Class 2 to 4, or would that start at 3?
3. Yeah, I would start at 3. Because class 4, these guys can't even get out of it. So I would say yes, class 3. So now how is this asked on an exam? Well, the number one example I got from a graduate, which I always share with students on NYHA heart failure classification, because students will say, what's in this for me? How is this even relevant? Well, the test question that was asked was, it was a med surg question, but then the patient was pregnant. So the patient was 36 weeks AOG, coming into the clinic for a routine visit. And the scenario said that patient had class 2 heart failure, not class 1. So class 2, we know that ordinary physical activity results in fatigue, right? So the patient is 36 weeks. So she's 1 week away from her due date. So the question was, what will you expect to be done during this visit? What do you think?
I guess heart assessments.
Well, the patient's about to give birth next week, and they have class 2 heart failure. So what do you,
Better rest.
Keep her at the hospital?
and they go into labor?
No.
Is labor ordinary physical activity?
No.
Yeah.
No.
Ordinary? I mean, I've never been in labor, so that's not ordinary physical. I mean, you tell me, have you ever been in labor?
It's not ordinary physical activity, Professor.
Definitely not. I don't even want to go through that.
So they would have to have a
Induced.
planned procedure done, a planned surgery, birth.
That was the answer.
Oh,
So
C-section, maybe.
yeah, that was the only answer that would make sense, because the patient has class 2, so there's no way they can give birth vaginally. They had to have a C-section, and that was the answer. So the answer was scheduled for coordinate, a schedule for a C-section. Right, so that's how this could be possibly asked, or it could be a child, for instance, who has this. All right. So this is the significance of NYHA heart failure classification. Any question on this table?
No, Professor.
All right, so let's move on. The rest of these are already in chapter 35, so I don't want to keep repeating them. ABI will be discussed in chapter 36. And this will be PAD, so we'll do that also in chapter 36. I think that's all we need for 33. The cardiac enzymes, we have a long ways to go. We have 2 semesters before that. We will come back to this in the 5th semester because won't make any sense. We'll discuss it now and it won't be tested until 2 semesters later. The same thing with these. This will be in chapter 35, so we'll discuss this next. All right, I think that's it for 33. Any question before we go? I mean, go to 35. No, not go home.
Got excited.
I won't do the entire chapter. It's too long. I'll just give you an intro, at least up to signs and symptoms, and then we'll call it a night. Okay, thank you for reading, Miss May Frazier.
Yes, from perfusion. Okay.
What is heart failure?
Heart failure, also called pump failure, is a general term for inability of the heart to work effectively as a pump. It results from a number of acute chronic cardiovascular problems that are discussed in this chapter and within the cardiovascular unit.
All right. So is it a primary disease? Does it say that?
No.
No, it's as what May said. This is a general term for the inability of the heart to work effectively. Therefore, it is a state or it's a condition. So you don't really stop at, let's say, the patient is diagnosed with heart failure. Your next question is, what caused it? Okay, because the heart failure can be managed, but unless you treat the cause, the underlying cause, then it'll be harder to manage. So meaning the patient either had a heart attack. Let's make it easy. We have a list here actually. Causing heart failure right here. Table 35-1. So these are the common causes and risk factors for heart failure. Meaning when you, again, like I said, when you see heart failure in the patient's chart on the medical record, your next question will be, well, what is the cause of his heart failure? That is the next question to ask. So how did he develop heart failure? How did he reach that state? And these are the causes. So therefore, when you see heart failure, there are any one or more of these conditions here that led to the heart failure. This is not a all-inclusive list. The list is longer than this, but these are the common causes. So hypertension, because what happens to your afterload when you have hypertension?
Increased.
High, right? Because the causes of hypertension is plaque deposits. So therefore it narrows the blood vessel, causing high afterload. Coronary artery disease. So here, coronary artery disease is there are plaques deposited within one or more coronary arteries. So what happens to your afterload here? Increases again. Plus it weakens the heart, right? Because there's now less blood flow going into the heart muscle itself. Cardiomyopathy, which we'll discuss later. This is heart disease, meaning the structure of the heart is abnormal. So can that abnormally shaped heart have a normal contractility?
No.
So you're getting the trend here. I'm trying to show you that it's all a matter of decreased contractility, high afterload, and high preload. So let's move on. Substance abuse. Let's say you smoke crack cocaine or any other stimulant, for instance. So what will happen to the workload of the heart here, or what will happen eventually to the contractility of the heart?
It'll wear out.
It will weaken the contractility. Let's move on to valvular disease. So either you have a valve that will not open or will not completely close. What happens to the afterload?
Decrease.
Increased afterload again, because there's higher resistance now, this time not imposed by the vessel, but imposed by the heart valves. Congenital defects. So if you have a hole, this will be discussed in peds because I don't have any adult patients in med-surg that have congenital defects. So this will be in peds. Okay, this will be one of the major cardiac topics for pediatrics. So I'll leave that for them, for Mrs. Buckner. Cardiac infections and inflammations. What will happen to the heart here if it's infected or inflamed? What happens to the contractility?
It decreases.
Decreases, and then so on. So we can go on here. All of these conditions either weaken the heart, meaning decreases the contractility, increases preload, or increases afterload, or any combination of the three. Let's go back here to the all right, types now. So it's important to note that heart failure has no cure. Well, technically, yes, there is. So you need a new heart. All right, if you can get a heart transplant, then yes, we've cured it. However, otherwise, then you'll have heart failure forever. So all you can do with any other chronic problem, like diabetes, for instance, hypertension, you can only manage it. So it's a chronic condition. However, it will have acute episodes, meaning if you don't comply with the pharmacologic and non-pharmacologic management of heart failure, then you'll have an acute exacerbation, just like COPD, or even diabetes. Okay, so all chronic disorders can have acute episodes if the patient doesn't comply with the management. There are three, however, we'll only test right and left side heart failure. So to distinguish the two, it really helps if you know your anatomy and physiology. We already discussed the classification. Okay, so we already know class 1 to 4, so we'll skip that. All right. The signs and symptoms here are mostly created by your compensatory responses or compensatory mechanisms. Now, remember this in chapter 11? Yes or no?
Yes, Professor.
Mechanisms? Yes, okay. So we had, in chapter 11, we talked about antidiuretic hormone. We talked about the Renin-Angiotensin-Aldosterone system, right? And then we also talked about the, I don't think we talked about sympathetic nervous system stimulation there. So here is the sympathetic nervous system. So what were the triggers again? In chapter 11, there were 4 triggers. Can you recall the 4 triggers that will automatically stimulate the RAS system and the SNS?
Lower than normal BP.
All right, low blood pressure. What else? What are the other 3?
Blood volume, sodium volume, oxygen.
Sodium, decrease oxygen. Perfect. So we have 4 triggers. Now imagine, let's say, heart failure, or more specifically an MI. So any of these conditions here, patient suffers an MI, has ischemic heart disease, hypertension, anything else. So will any of these conditions lead to one or more of the following? Decreased cardiac output, decreased blood volume, decreased sodium, decreased oxygen. Is it present in any of these conditions here? Let's take MI, for instance. So somebody has a heart attack. Will that decrease cardiac output?
Yes.
Yeah.
Will that decrease oxygen delivery?
Yes.
Yes.
Okay, so it takes only one. You don't need all four conditions in order to trigger compensatory mechanisms. Okay, and this occurs within less than a second. So the moment cardiac output drops, you don't need minutes. Your sympathetic nervous system response is automatically triggered. And at the same time, your renin-angiotensin system is also activated. Now, I'll give you an example. If I hide around the corner and then when Miss Escobar, for instance, comes around and then I scare her, right? I suddenly pop out of I don't know, a vase, okay? I don't know if a vase will fit, fit in the vase, but you know, I come out and then I scare her. Does it take 5 minutes before her heart rate increases and her skin to turn pale and feel cold and clammy?
Nope, it take like a split second.
Yeah, less than a second. So this is how fast this thing is activated. Same thing for your renin-angiotensin system. Have you ever had a moment when you had to go to the bathroom, number two, okay, number two, so bad, but then something scary happened, and then all of a sudden you didn't need to go to the bathroom anymore?
Yeah.
Right? Have you ever been in that situation?
Thankfully, no.
Absolutely. Absolutely.
These are again examples of sympathetic nervous system activation, because what happens in let's look at sympathetic nervous system. So how exactly does your you show the symptoms? Why does your skin turn pale? Why does your skin feel cool and clammy? And then why can't you go to the bathroom? Okay, in fact you start vomiting. Okay, so the answer here is there's two effects here. So epinephrine will cause high heart rate, that's obvious. And then of course vasoconstriction. And then when there's vasoconstriction, there's meaning the vessels that are prioritized here are the central vessels, meaning the body considers all peripheral organs, namely the skin, the GI tract, even the kidneys. They are not essential organs. So the essential organs here are only the heart, the lungs, and the brain. So those are the only organs that will receive normal blood flow. All other organs or parts of the body doesn't get enough blood, that is. So therefore, GI tract stops running because there's no blood flow to it. No peristalsis, no way for gas or anything else to pass through. That's why you forget about number two. Okay, there's no more stimulus because it just stops. And then but however, because there's no peristalsis, you get nauseous, and then you start vomiting. The skin, of course, doesn't get any blood, so skin turns pale, and then it activates your sweat glands. You turn sweaty. And then on the other hand, what's happening here in the RAS is you'll have further vasoconstriction. So angiotensin 1 turns into angiotensin 2, causing further vasoconstriction. And then aldosterone is also released. So therefore, instead of you making urine, you're not, because sodium and water is reabsorbed, increasing preload. So here, look at the effects of these compensatory mechanisms. So your heart rate increases. What will happen to myocardial oxygen demand when your heart rate increases? How much oxygen is your heart consuming when your heart rate goes up?
A lot more than normal.
Right. But in the first place, how did this occur anyway? By the way, so what led to the sympathetic nervous system activation? What was the number one trigger? Was there enough oxygen circulating?
Oh, we're going from low BP?
No.
Yeah, the whole thing, in the first place, why was SNS activated?
Because BP was low.
And the oxygen level was also
low.
Yeah, that was the number one trigger. But yet, what is the SNS? What is the epinephrine asking the heart to do?
Speed
What-
up.
Compensate.
How much oxygen is the heart now consuming? Because it's now working harder, working faster. How much oxygen is it consuming? I'm sorry?
Got a mute showing me.
The question was, how much oxygen is the heart now consuming? Because it's now beating faster. More or less.
Needs more oxygen.
All right. And again, what was the number one trigger? Did we have oxygen in the first place?
Nope.
No.
But yet, what is epinephrine doing? Epinephrine is making the heart consume more oxygen. Is that a very smart thing to do?
No.
No. Like when you're out of money, you're broke. Do you respond by splurging the last 10 bucks on cigarettes? Or
I spent on cigarettes, but you know.
no, I'd rather buy a dozen eggs and some ramen noodles, right? That would be good. And look at the renin-angiotensin side. What's it doing to the afterload? Because it's causing further vasoconstriction happening to the afterload.
Increasing.
The aldosterone part, which is now reabsorbing water and sodium, what's it doing to the preload?
It's
Increasing.
Afterload, it's increasing preload. Are these two beneficial to a patient who is having low perfusion in the first place?
No.
No, this is not a very smart thing there's not a very smart way to respond, but this is exactly how our body responds. So are we helping the heart here or are we killing it?
Killing it.
We are killing it. So therefore, do we need these two guys here, these two responses to continue?
No.
No.
No. So without even going to the intervention part of chapter 35, what drugs will we need to give in order to stop these two guys here?
Beta blockers.
Beta blockers.
Number one is beta blockers. What else? So that stops the sympathetic nervous system response. What do we do about the other one? Because it's also occurring at the same time. What drug can you give to stop this part? You give beta blockers here, we'll stop the SNS stimulation. What about this part? What drug?
Calcium channel blocker?
I'm sorry?
I was gonna say, is that the calcium channel blocker? I can't remember.
Well, calcium channel blocker is like a sister to beta blockers. So they have pretty much the same effect. They're like siblings. What about this part here? How do you stop the renin-angiotensin-aldosterone system?
What about steroids?
No.
A drug that does vasodilation.
A drug that
The name
fluid to decrease.
Diuretic?
Okay, good.
Antidiuretic, yeah.
Yeah, we can give diuretics in order to decrease the preload, right? But what about this part here? Because this one has two effects: causes vasoconstriction, and which is increasing afterload, and increasing preload by reabsorbing sodium and water. So what drug will stop this whole operation?
ACE inhibitors.
Very good. We give the patient ACE inhibitors. ACE inhibitors will therefore stop this renin-angiotensin-aldosterone system response. All right, so you just gave me interventions without even looking at the latter part of the textbook. All right, so you understand how heart failure works and what we can do about it.
Yes.
All right, so this is now how why patients are on beta blockers when they're in heart failure, And this is how they're on diuretics, they're on ACE inhibitors when they're in heart failure. And these are everyday medications they have to take for the rest of their life. All right, so let's go to signs and symptoms, and I'll let you go. You can read there are two big paragraphs here, like this one, left-sided heart failure. It tells you the symptoms, and then the same way with right-sided heart failure. I'll go straight to two charts, chart 35.1 and 35.2. The key here is in the title. Look at the title of 35.1 because this is left ventricular failure, right? Look at the two problems that result. The patient has decreased cardiac output as well as pulmonary congestion. So it takes you back to how you can remember this is, if you know what is the job of the left side of your heart, the left ventricle, what is its job?
To receive, no, to pump
Pump
blood.
blood.
What?
It's a pump.
To pump blood. To pump oxygenated blood.
Okay, so it pumps
into
blood
the system.
Okay, to the systemic circulation. So therefore, does it determine cardiac output?
It does.
Yes, it determines cardiac output because this is the last ventricle that will pump blood to the aorta. So therefore, whatever blood comes out of the left ventricle is your cardiac output, right? And that's the blood that's going to be distributed to the rest of the body. Somebody said earlier about receiving. It receives what? Because this is just one of its jobs. It has two jobs. What is the other job of the left ventricle? In order to do job number one, what must it do first?
It has to receive
oxygenated blood.
Very good. It has to receive the blood from somewhere. So it receives blood from the lungs. So the left and right lungs drain blood, oxygenated blood, into the left atrium and then finally into the left ventricle. So there are two jobs that the left ventricle must do. One is to produce cardiac output. The other is to receive blood from the lungs. Can it do both when it's in failure?
No.
No. So these two are non-existent. There is decreased cardiac output, plus there will be pulmonary congestion because now it cannot, if it can't get rid of the blood in the left ventricle, therefore, whatever blood that was supposed to enter it has to back up somewhere. So here in left-sided heart failure, if the left ventricle is injured or is in failure, there will be no blood receipt from the lungs. So therefore, blood backs up into the lung. There will be pulmonary congestion. And these are your signs and symptoms of pulmonary congestion, which are consistent with pulmonary edema. So the patient has this cough, a pink pinch, frothy as well. You'll hear crackles in the lungs because it's now filled with all this water because of the edema that forms there. Meanwhile, there's no or very little cardiac output. And we already know no blood getting to any of the cells. Of course, you'll have fatigue and weakness. Is there enough blood getting to the kidneys? No, not during the day at least. So you'll have oliguria during the day, and this nocturia here is now going to contribute to the fatigue because they'll be getting up several times a night. And don't forget about the paroxysmal nocturnal dyspnea that will awaken them short of breath after a deep sleep. And of course, angina because there's less blood flow to the myocardium itself. No blood getting to the brain, you'll have confusion, restlessness, dizziness. This is the compensatory response because the decreased cardiac output automatically within seconds or even less than a second causes epinephrine. So therefore you have your palpitations here, increased heart rate, plus the cool, clammy skin here, cool, clammy extremities, and then you have pallor because there's vasoconstriction. And again, because there's no cardiac output, not enough blood getting to the kidneys, how much more the legs. Okay, so you'll have weak peripheral pulses. Any question on the left ventricular failure? All right, so that wasn't so hard, right? So let's go now to the right side. Now, what's the only job of the right side?
To
Carry.
Receive blood.
blood and pump it to the lungs.
All right, so it's supposed to receive blood from the upper and lower parts of the body. Can it do that if it's in failure?
Nope.
Nope. So there's traffic everywhere now. So that's why the title of the chart is systemic congestion. So congestion everywhere. So from the upper and the lower parts of the body. So let's start with the upper. So if blood from the brain cannot drain into the right atrium because it's in failure, blood is not moving out of the right ventricle. It's trying to pump, but it can't because it's injured. So therefore, blood backs up to the head. You'll have on top of the headache, you also have distended neck veins, and then that's pretty much from the upper. From the lower, so since all the blood from the GI tract and even your lower legs has to pass through the liver, because that's how the vessels are constructed, all the vessels have to go through the liver before they enter the inferior vena cava, and there's traffic there now, so the traffic goes back and back further and further. So let's start with the liver enlargement, and then the spleen, and then the rest of the GI tracts now cannot drain, so that will stimulate nausea and anorexia. Eventually, the increased hydrostatic pressure will cause blood to leak out now. I mean, not blood, water to leak out of the vessels, out of the veins, and then they'll accumulate to any dependent area. So this could be not only your leg sacrum, but let's say this patient will be in a recliner, right? Because they can hardly breathe and they have orthopnea. So they'll be pretty much in a recliner, correct? So the dependent areas when you're in a recliner or in a reclined position, because they can't lie down flat, so they're in an orthopneic position. So that would mean your elbows will also be dependent areas. So even your scrotum will also be in a dependent position. So you have water in all of those areas. And water, besides leaking, because now there's a congestion in the liver and the spleen, so that water will also leak from there and go into the abdomen, forming ascites. And because the hands and fingers will also be in a dependent position, they'll also have edema and swelling. However, like we discussed earlier, there's all of these water will return at night. So when the metabolic demands are lower at night, all of a sudden cardiac output improves. So now all that water returns into the vascular circulation, increasing blood volume, because now they're not in the interstitial space anymore, increasing blood flow to the kidneys, causing the polyuria. So polyuria at night pretty much means nocturia. And the weight gain, of course, is from the oliguria during the day. Now this part here, there's two blood pressure problems here. When we say increased blood pressure, they have hypertension day to day, meaning, remember, heart failure is a chronic condition, correct?
Yes.
Okay, so every day they will have high blood pressure because what happens to their preload every single day? Because you're in heart failure.
Increased preload.
Okay, you have high preload. That's why you have to take diuretics in order to get rid of the excess volume. However, on exacerbation days, when they're having an acute decompensation episode, when they're hospitalized, they do have decreased cardiac output or decreased blood pressure. Does that make sense? Meaning they'll have low cardiac output or low blood pressure when they are in acute failure. However, again, because the patient in heart failure this is a chronic condition, so every day they deal with increased blood pressure because of the high preload, because their output is low, so therefore less blood leading to oliguria, leading to water retention, leading to weight gain. Does that make sense? However, when they're in decompensation, meaning acute failure, maybe they didn't comply with the diet, that's usually the cause, or did not take their medications as they should be. So they go into an acute exacerbation, cardiac output drops. Any question in particular? But I encourage you to please read the paragraph left side and right side on your own. That will explain what I just blabbered about. All right.